Good morning. Today I'll be presenting on effectiveness of transcleral diode laser cyclophotocoagulation in refractory glaucoma. So the aim of the study is whether diode laser is an effective tool in in lowering the intraocular pressure in refractory glaucoma. So this is a retrospective study where all patients of 2021 to 2022 were reviewed regardless of the glaucoma type or stage, and patients less than 6 months of follow-up were excluded from the study. So after taking an informed consent, uh, the diode iridex machine with the parameters of 1500 to duration of 3000 and giving giving peribulbar block, the G probe was kept perpendicular to the limbus, and superior and inferior quadrant was diode laser was applied at avoiding 3 o'clock and 9 o'clock position, and the parameters were adjusted just to avoid a pop. At the end of the procedure, 0.1 ml of dexamethasone was given. The intraoperative documentation and postoperative care included topical steroids, anti-glaucoma medication, and oral non-steroidal anti-inflammatory drugs and carbonic anhydrase inhibitors were given for a short course. During the follow-up visits, the visual acuity assessment, intraocular pressure, anterior segment evaluation for complications were analyzed, and the complete success was defined as IOP less than 22 without any glaucoma medication, and qualified success was IOP more than 22 with glaucoma medication. Failure was defined as IOP more than 22 with maximum anti-glaucoma medication, any hypotony related cases, and need of additional cyclodestructive procedure, and increase in the number of anti-glaucoma medications after 4 weeks. The secondary outcome was the visual deterioration. That is, if there is a persistent drop in the visual acuity for more than 3 months, and all the data was statistically analyzed. So out of the 110 eyes reviewed, the mean age was 57.84, and all the patients had undergone local anesthesia. Only 2 patients had general anesthesia, and the maximum number of cases who had underwent diode was the neovascular glaucoma, and of the 110 eyes, 6.36 eyes had previously failed glaucoma surgery, and 27% had retinal surgery, and one patient post micropulse neovascular glaucoma had undergone diode at 2 months post-operatively. Then the among the 110 patients, only 56.3% had 6-month follow-up, and 40% had 1-year follow-up. And most of the patients, diode was done in 93.6% patients was for pain relief and reduction in IOP. The visual acuity outcome at 1 year, there was an improvement in visual acuity in 5 patients. It was unchanged at for 30 patients, and decrease in visual acuity in 9. There is a statistical decrease in the IOP, that is from 39.7 to 19.5, and the average number of anti-glaucoma medications was reduced from 3.03 to 2.42 at 1 year follow-up, which is not statistically significant. Complete success was seen in 28% eyes, 46% showed qualified success, and failure was seen in 24% eyes. The most common complication here was the decreased visual acuity. Then coming to the discussion, mainly diode is done for eyes with poor visual potential and painful blind eyes. And complications like pain, phthisis, and prolonged inflammation has been reported. Various studies, and our study shows that diode is having a significant IOP reduction and favorable complication profile in refractory cases of glaucoma. Then in our study, the power used was 1500, and the duration was 3500. So as a result, there was a decrease in the post-procedural inflammation in the early post-operative period. And the POP was also titrated by 250 millivolt. Therefore, it minimized the tissue coagulation accompanying the post-operative inflammation. This is a study done by Sklow et al., which is comparable to our study, and they showed a success rate of 77.3, whereas our success rate was 74%. And in Sklow et al., the IOP reduction was 18.7. In ours, the IOP reduction was 20.17. The loss of visual acuity, that is in 9 eyes, it is basically due to the end stage of the disease. And two patients had phthisis in our study. That is basically due to the scleral thinning which we had. And our results suggest that for such cases, the titration of power and duration of laser energy, this potential complication could be largely avoided. The limitations of our study is the retrospective nature, and proper documentation of post-procedural pain and inflammation was not correctly documented, and several patients defaulted in the follow-up visit. To conclude, diode laser can be used in cases of refractory glaucoma in candidates with poor filtration surgery. These are my references.
You had two patients with phthisis, right?
Yes, sir.
So what was the underlying cause in those patients? And says, was it NVG? What was the reason for the glaucoma in those patients?
Both the patients were the pediatric patients, basically. They had several areas of scleral thinning, but we had avoided those areas, but still they developed this one. One was a traumatic cataract, and other one is an aniridia case.
So you were doing 360 degrees, basically. Yeah, so that's one of the, so normally most of the time when we do the diode for the first time, we treat 180 degrees.
Okay.
And we usually don't, your settings are low, 1.5 is okay, but the 3 milliseconds is actually pretty high. 3000 milliseconds, 3.5 seconds is fairly high. Your phthisis rates of 2 out of 44 are actually not low. That's about 5%.
Yeah.
In the reported literature nowadays, it's around 2%. And considering that you have a significant dropout rate, the rates may actually be a little higher. So 360 degrees as primary diode, especially in somebody who's never undergone a glaucoma procedure before, is maybe a little sort of more aggressive than what is normally recommended.
Have you repeat in any patients?
No, we didn't repeat in any patients. It was 1 week, 1 month, 3 months, and 6 months, and 1 year follow-up. It had fallen down to 44 eyes. Thank you.